Respected panelists and dear learned audience, Assalamu alaikum and a very good morning. I'm Dr. Abeeda Tasnim Reza, Associate Consultant, Clinical and Interventional Cardiology, Evercare Hospital, Dhaka. Welcome you all on today's presentation, and the title of my presentation is a rare condition presenting with wide complex tachycardia. Let me start with my case summary. 49-year-old female hypertensive diabetic presented to the emergency department with the complaints of palpitation and transient loss of consciousness for 2 to 3 minutes 1 hour back with and sudden weakness of both lower limbs for last 3 hours. And on quick physical examination, her pulse was not palpable, blood pressure was non-recordable, patient was restless, ECG was recorded immediately and cardiac monitor was attached, and the cardiac monitor showed wide complex regular tachycardia, so we went for DC cardioversion of 150 joule shock was given for 2 times, and following the DC cardioversion, her pulse became sinus, it was regular, blood pressure became recordable, and the neurological examination of motor examination showed that there was reduced muscle power with tone along with diminished jerks, but plantar response was bilaterally flexor. So this was the ECG. She was presented at emergency department, and if we look into the ECG, we can see that there is wide complex regular tachycardia in RBB morphology. So whether this wide complex regular tachycardia is ventricular or supraventricular origin, that's we have to find out. And we went for the Brugada criteria. If there is absence of RS complex or concordance present, see, it is most likely ventricular tachycardia. Here we can see the positive concordance in all the chest leads, so it's most in favor of ventricular tachycardia. Then we measured the R2S in the next point is if it is more than 100 millisecond in any chest lead, it is most likely due to VT. So we measured it and it is more than 100 milliseconds. So that's another point in favor of ventricular tachycardia. The second, if there is any AV dissociation, but we could not find any AV dissociation. And the third one is if the morphological criteria in lead V1 and V6 is in favor of ventricular tachycardia. As it was RBB configuration and QRS was widely wide, and we found out that there is R in V1, so we differentiated it, and it's the ventricular tachycardia. So what is the origin of this ventricular tachycardia? As there was RBB, so it is most probably is originating from left ventricle. And secondly, we look into the 2-3 AVF, and here we can see these are positive. So if it is positive, it indicates its inferior axis, and the ventricular tachycardia is originating from outflow tract of left ventricle. So this is how the ECG looked after the patient became sinus rhythm. And here, if we look into the ECG, we can see that there is flattening of T wave base noted in the inferior leads with prominent U wave, and there is apparently long QT, actually the long QU interval. So we sent out all the baseline investigations, including the serum electrolytes, and it came out to be 2.2, which is extremely low. So we treated the patient with IV KT followed by oral potassium, and patient's lower limb weakness fully improved after correction of serum potassium. And on query, she gave similar story that lower limb weakness with 2 hospitalization, and documents shows both the time she had low potassium. So what are the causes of hypokalemia in this patient? It can be due to reduced dietary intake, redistribution into the cells, loss through kidney or GI tract. So we tried to find out the cause, and urinary potassium for 24 hours was done, which was less than 30 millimole per day. So it either may be due to gastrointestinal loss or due to redistribution of the cells. But all the history of the patients revealed that there is no history of loss, that no vomiting or diarrhea or any other drugs. So our most finding was it was due to hypokalemic periodic paralysis, as there are 2, or if there is that consensus diagnostic criteria are if there are 2 or more attacks and less than documented serum potassium level, and improvement in symptoms with potassium intake, and exclusion of all the causes like renal, adrenal, thyroid dysfunction, etc. So our final diagnosis was ventricular tachycardia reverted to sinus rhythm and hypokalemic periodic paralysis. Thank you all. Thank you for your patient hearing, and thank you IPDI for giving me the opportunity.